Ah, tô vendo.
Hey, webinar, and thank you for joining us. My name is Augusto César. I'm assistant professor in the Department of Epidemiology, Human Genetics, and Environmental Science here in the UT Health School of Public Health in Austin. Today, our webinar is hosted by Michael and Susan Dale Center for Health Living at UT Health School of Public Health in Austin. And the center vision is Help Children in Health World. Before we get started, I just wanted to make some housekeeping announcement. This webinar is being recorded and will be archived along with this presentation slides on our website at mesdcenter.org. If you have any questions during the presentation, please enter them into your question box. I will have time for a Q&A at the end of the presentation. I'm so excited to introduce our speaker, Dr. Alexandre Chiavegatto-Filho. He has Bachelor in Nutrition and Economics from University of São Paulo, PhD in Public Health from School of Public Health at the University of São Paulo, postdoctoral researcher at Harvard University, and nowadays he is Associate Professor at the Department of Epidemiology of School of Public Health at the University of São Paulo. And he's the director of the Laboratory of Big Data and Predictive Analysis in Healthcare, LabDAPS. And also, he is a principal investigator of machine learning and health outcome prediction, funded by São Paulo Research Foundation, Ministry of Science and Technology Innovation of Brazil, Microsoft, and Harvard University. So I will hand over to Dr. Chiavegatto-Filho to start the presentation entitled Machine Learning for Improving Healthcare Decision in Sanitation Areas. Thank you, Alexandre, for being here. It's a great pleasure for us.
Thank you very much, Augusto. It's a pleasure to be here. Thank you all for having me here at the University of Texas and at the Dell Center. I'm going to talk to you about my area of research, which is machine learning in healthcare, how we have been applying machine learning for hard, complex decisions in healthcare, which is the most difficult area of them all. And it's going to be the area that machine learning is going to be the most important in all of science. So I'm going to talk to you a little bit. I'm going to try to make a brief. Are my slides on? Are they on? Okay, I'm just not seeing them. I'm not seeing my slides anymore. So I'm really not seeing anything. Just a second as we figure this out, because I was seeing everything and now I'm not seeing anything. Okay, now I got it. Okay, I'm seeing it. Thank you. I'm going to talk to you about machine learning for improving healthcare decision in disadvantaged areas, which have a few interesting challenges that I'm going to talk to you about, how to make these algorithms work where they are most needed, right? Which are the poorer regions of the world, especially Brazil. So I'm from Brazil. I'm an associate professor, as Augusto said, of machine learning for healthcare at the University of São Paulo. And as you all know, Brazil has plenty of challenges regarding socioeconomic disparities. And we want to use these algorithms in the remote areas of Brazil, which have a few interesting technical and practical challenges to be implemented. So just a very brief introduction to what machine learning is. It's a very interesting time to be working with machine learning. I've been giving these talks for about 5 to 6 years now, and in the very early beginning, I used to have 80% of my talk was just intuition, an explanation of what machine learning was all about. And now, as more and more people know about the field, it's a great pleasure for me that I only have one slide now of introduction, just a very brief intuition for you, just to keep everyone in the same place of what machine learning brings of new things for our area of public health, for our area of epidemiology. So what is machine learning most used for? It's most used for prediction, right? Which has not been common in public health ever since recently. So what we usually do in public health, and it was how I was trained, and it was how most of you were trained back in our PhD, back in our master's, back in our bachelor's, is that science in public health is basically finding association of factors, right? Which in machine learning, we call this type of study inference studies. So we're trying to see if one factor is associated with another. So if smoking is associated with lung cancer, if exercise is associated with cardiovascular health. This is 95% of public health science up still now, okay? And it was, and back in our day when we were PhD students, was 100%. Now we have 5% that is prediction, and it has been growing a lot, and I think eventually it's going to be 50-50. But as of right now, still most of the studies are still inference, which is a very important area. As I told you, inference, the association studies. With machine learning, we're usually interested in prediction, right? We're trying to predict an outcome, usually a negative health outcome. So I'm trying to predict if this patient right in front of me is going to have an important disease in the next few years, for example. Or if this patient right now in my ICU, if this patient is going to end up dying in the next few weeks and so on. I'm going to give you plenty of results, of recent results from my lab regarding prediction. What is important here is that it's not our main focus to find association between factors, which is very important, because if we're not trying to find direct association of factors, we are free to model the world. And the world is a very complex place, especially in healthcare. Okay, so in healthcare, we don't have any disease that is just caused by one single factor, completely independent of everything else, right? So every negative important outcome in healthcare, it's usually an association, a very complex association of many different factors. Okay, so no one dies just because the person is sedentary. No one dies just because has bad nutrition habits. Okay, it's an interaction of plenty of factors, of genetic factors, demographic factors, socioeconomic factors, environmental factors that interact in a very complex way, leading to negative health outcomes. And it's exactly for that machine learning works so well. Okay, so machine learning is able to understand this complex interaction of factors that lead to a special outcome, to a specific outcome. Okay, and because we are not bounded by giving simplistic explanations of these associations, we're free to model the real interactions between them, which are complex, which are multi-causal, leading to these factors. So the algorithms are able to learn how these variables interact in a complex way, leading to this type of outcomes. So this is basically what machine learning is doing. It's finding this curve fitting, right? We're fitting the data to a curve, and we try to make predictions out of this. And then we test the predictions. A very important thing about machine learning is that we always test the predictions in new unseen data, right? Machine learning is a very practical area. We want to put these algorithms into clinical practice, into health management practice. So we always report how these algorithms would perform in terms of predictive performance in new, never seen before data. Okay, it's very easy to predict the past. We want to predict the future with machine learning. Okay, so we train the algorithms with known data, with data that we have, that we know the outcome. So the algorithm learns with this data, and then we bring new patients in, and we see if the algorithm, with what it learned from the past, is able to predict the new patients. And this is the only data that we report. Okay, we only report the results of the algorithms with new, unseen data. Okay, and for that we have many options of algorithms that are able to learn these very different interactions, different factors. For structured data, which is the most common type of data in healthcare, and the type of data that my lab specializes on, usually the algorithms that work better, it's the algorithms that we call gradient boosting algorithms, especially XGBoost, LightGBM, and CatBoost. Okay, but we have plenty of other algorithms that we're able to fit to this data. Okay, for example, random forest works pretty well. Neural networks doesn't work so well for structured data. And you've heard about deep learning, right? Deep learning works really well for images. It works really well for text, but doesn't work so well as of right now for structured data. So what is structured data? Is the type of data that you can put on a spreadsheet. Okay, so it's the majority of health data that we collect. For example, demographic characteristics of the patients, results of the majority of the exams, vital signs of the patients, blood counts of the patients. So most of the healthcare data that we use on an everyday basis is structured data. So we develop algorithms that learn from this structured data and are able to make a prediction. Okay, so this is my very brief introduction. I teach a whole class, a whole course at the University of São Paulo about machine learning for healthcare, but I wanted to put everyone on the same side. So, what kind of studies have we been developing recent? So I'm going to show you a couple of our recent results. So this one we have a large network now in Brazil for artificial intelligence for COVID-19. Oh, I forgot to tell you about artificial intelligence. So how does artificial intelligence get linked with machine learning? What is the difference? So machine learning is when machines learn to make decisions through data. Okay, we have two ways that machines can make intelligent decisions. Either you program them directly, right? Which now we call it GoFi, good old-fashioned AI. So you program the rules directly in the computer, and the computer just follows the rules that you programmed. So this is GoFi, good old-fashioned AI, as we call it now. Or you can have the machine learn the rules through data, and that is machine learning. Okay, machine learning now pretty much dominates artificial intelligence. It's almost a synonym. When we're talking about artificial intelligence, if you see any news on artificial intelligence, you can be sure that it's machine learning. Okay, because the algorithms, by learning by themselves, are able to understand much more details on how to make the prediction than if we had to program the algorithms line by line of code. Okay, so I'm going to talk to you about some of our most recent results. So we have this network for AI in COVID in Brazil, and this is an article that we published last year, where we developed machine learning algorithms to predict, given that the patient has COVID, what are the odds of this patient with these characteristics ending up in the ICU, ending up needing mechanical ventilation, or ending up dying. So here we find that the algorithms work really well to predict all of these three outcomes. So with past data, we train the algorithms to learn how to predict, to learn the rules of prediction in order to identify the risk of each patient end up dying, end up needing mechanical ventilation, or ending up in the ICU. And then we got new patients, and then we saw how well the algorithms predicted correctly what was going to happen to these new patients, right? And we ended up going a little bit further in an area that my lab is really interested on, which is what we call multi-purpose algorithms, which is given that an algorithm learns one negative outcome, does it work for other negative outcomes that the algorithm has never seen before? And we showed here that it did work pretty well. So if when we develop an algorithm to predict death, and this algorithm has never seen a case of, for example, ICU, it was able to predict pretty well if this patient would be going to the ICU, even though the algorithm has never seen a case like this before. So the algorithm is learning to predict severe outcomes as a whole, which will be very important for healthcare, because if we need a different algorithm for every single possible negative outcome, we're going to have hundreds and hundreds of algorithms. But if we have one master algorithm, one multi-purpose algorithm that says to the physician, that says to the healthcare manager, okay, this patient right here is probably going to have a very severe outcome in the next few days or in the next few weeks. It's going to be much more important for the managers and the physicians in order to decide if you keep this patients in the hospital or you let them go home. Okay, so the first example. Another example that was published late last year was we have a cohort of elderly patients in São Paulo, Brazil, where we have been following them for 20 years now. So we got the data from way behind, and we trained algorithms to see if, given these characteristics of the elderly patients 5 years before, are we able to predict the risk of death in 5 years of these elderly patients? And if yes, which causes of death, specific causes of death, are we able to predict better for these elderly patients? So we found that we could predict really well death by respiratory diseases, but not so well for cancer. So we have been working now to understand and try to identify why are we able to predict so well mortality by respiratory diseases, but not so well for cancer. It's probably due to the type of variables that we had in this study. As I always say to my students, I don't know any health outcome that is completely random. So we have no important health outcome that comes completely out of nowhere. If we have all the variables that we want, we're able to predict any health outcome in due time. So nothing in health comes out completely out of nowhere. So given a due time, we're always able to, and given that we have the perfect variables, all the variables that we want, we're able to predict any important health outcome. The issue is that most of the times we do not have these variables, right? The perfect variables that we wanted to have. We have to work with what we have. So sometimes we do not get a good prediction in due time, of course. It depends on the disease, how before you can predict. And another interesting thing regarding a very important area for machine learning is the targeted interventions. So machine learning is a very practical area. It's going to be widely used in the clinical practice, but it's going to be really, really important for public policy too. Okay, so which kind of individuals, of patients do you want to have inside the public policy? The individuals, the patients that are going to be meaningfully impacted by this policy, right? So you need to predict who is going to end up having the issue that you're trying to tackle with this policy. So in every single public health policy, you cannot give every single public health policy to every single person. Okay, you have to predict first who is going to be positively impacted by this, by the policy that you're interested in. So this is a machine learning problem. This is a prediction problem to get the right persons inside this public health policy. And here we found that only among Did I lose again? And let's see it again. So among this is not okay, I see it. I see it now. Okay, so this is really small. Okay, it'll work. So among the okay, nice. So among the 25% individuals with the highest predictive rate of respiratory disease mortality, we got everyone. Okay, so what do we usually do when we finish this type of analysis? We see if we only had a policy, a public health policy for only 25%, who would we choose? For example, a public health policy to prevent respiratory disease mortality. Okay, we would use only, for example, 25%, and we would select those that have higher risk according to our algorithms, and we would, within this 25%, have every single person that would die for respiratory diseases in the future. Okay, so this is targeted public health policy. I cannot pass the. I'm able to pass the slides. Can you pass the slides? Okay, I stopped being able to pass the slides. Let me send it to you, and then you can pass the slides.
Yeah.
Oh, I just saw it. Oh no, now you're seeing your camera. Okay, so Augusto is gonna pass my slides. Sorry. I know what happens. I just click on anything and it stops showing. So yeah, right there. That's good. So thank you. So another one last study that was published by our lab this year. We tried to predict mobility decline of elderly patients, again using the same sample that we have been following for 20 years in São Paulo. We tried to develop algorithms to predict who is going to have a mobility decline in the future. So the elderly patients that do not have a mobility decline, given their characteristics, who is going to have a relevant mobility decline in the future. And we got pretty good results, especially for mobility decline associated with crouching and kneeling and lifting or carrying weights. And the interesting thing here is that we got better predictions for specific mobility declines than for mobility declines as a whole, even though we had less data. Okay, even though the number of individuals that had a specific mobility decline was lower than had overall mobility decline. Even though we had less examples for the algorithm was better at predicting this. Okay, so it was an interesting result that even if we have less data, if we have more specific health outcome, the algorithm learns better, okay, than an overall mobility decline outcome. Okay, and then okay, so our lab, it's called LabDAPS, as Augusto said. It's the big data and predictive analytics lab at the University of São Paulo. And despite Brazil lack of science support currently, we are very fortunate to have the financial support of FAPEST, NPQ, the Lehman Foundation, Microsoft, and now we have a direct funding from Harvard. So the main goal of our lab is to help to improve healthcare decision, especially where it's going to be most needed, which is disadvantaged areas. What are the two greatest challenges to get these algorithms where they are most needed? First of all, we have less variables, right? Disadvantaged areas collect less variables. So how do we get these algorithms to work where in places where you do not collect much information about the patients. So machine learning is not magic, it's not miracle, it's just curve fitting, right? We're trying to get this data in a curve, and we're trying to use this curve to predict what is going to happen to each of the patients. And we need to have these variables for every single patient, okay? Otherwise, the algorithm won't know what to do with this specific patient. So I'm going to show you how we have been working on this. And then the second biggest challenge for using machine learning in disadvantaged areas is how do we make those algorithms available? Okay, very poor regions of Brazil do not have electronic medical records. Okay? So we're not able to just put these algorithms within the electronic medical records. Most of these regions still use paper medical records. So how do we give this information to the physicians to improve their decisions in these disadvantaged areas? So the first challenge, which is how do we work with less variables? So we have been working with this a lot. We had a paper also last year on this with funding from the Gates Foundation, where we tried, okay, from our previous studies that I showed you, we collected the data, right? Here, we said we're just going to use mandatory collected data and see if the algorithms work with the data that we have to collect for every single patient. In this case, to predict neonatal mortality, okay, mortality in the first month of life of newborn babies. Can we use this official mandatory collected data to predict which baby is going to end up dying the first month of life? Okay, so we use data from 2012 to 2017. We did a linkage of every single birth and every single neonatal death in São Paulo, Brazil, from 2012 to 2017. And what did we do here? We used data from 2012 to 2016 to train the algorithm, so the algorithm will learn the rules of decision. And then we used the last year, we hit the patients from last year, and after the algorithm learned from 2012 to 2007 and 16, we're like, okay, you have to guess what's going to happen to these patients from the year that you never seen before, 2017. Okay, so these are results, and our results were really, really strong. We got an area under the curve of 0.97. And then we went to the second step. Okay, we're already using only publicly mandatorily collected data. Let's try to use even less data. Okay, so if we want to get this algorithm to work maybe in countries that collect less data than Brazil, let's use the 5 suggested minimum collection of data from the World Health Organization. And even if when we use only 5 variables, only the 5 ones that are suggested by the World Health Organization, we still got a very high area under the curve of 0.91. Okay, and here again, thinking about targeted public policies, if we only got 5% of those babies, of a total of the total of babies in a public policy to prevent neonatal mortality, only using those 5% with the highest risk according to our algorithms, we would be intervening in 90% of every single future mortality. Okay, we only need to have a public policy for 5%. If you use the ranking from the algorithm in this 5%, that would be pretty much every single neonatal mortality in the future. So very targeted public health policy, very, very cost efficient to run this. And then, okay, so the first thing, as I told you, is the okay, back here. So the first thing I told you about the first challenge, which is using less data. And people have a wrong impression that machine learning needs millions and millions of data. Not always. The most important thing is have good, strong variables, good, strong predictors. Much more important than having many patients or many variables. Okay, for plenty of our studies, we only need very few patients if we have the right variables, the right predictors. Okay, so we usually do not need that big, huge amounts of data for machine learning in healthcare if we have very strong predictors. Okay? And the second challenge, like I told you, how do we get this algorithm to work in disadvantaged areas? So we developed a digital app called Random IA, right in Portuguese, Inteligência Artificial, so Random Artificial Intelligence. We got funding from Microsoft here in the US that opened an international grant, and we were able to be one of those that got it. We developed a digital app to perform randomized controlled trials for machine learning in healthcare, which is what we call artificial intelligence 2.0, which is, we have been finding us and other machine learning groups in healthcare around the world, that machine learning algorithms are able to predict health outcomes pretty well in the lab, right? Artificial intelligence 2.0 is, does it change clinical practice? Okay, does it change clinical practice enough to prevent those outcomes from happening? Okay, so if the physician has this information, does she use this efficiently enough to prevent the outcome from happening? So this idea behind our app, and we're able to give this app to directly to physicians, right? Even though if the hospital or the place does not have an electronic medical record, the physician for sure has a smartphone or has a tablet or has an iPad. So we developed this where the physician is able to write down the information of the patients, and we have the algorithm inside the app, and it runs inside the app, and then it gives a prediction. Okay. The first thing that we need to know with this kind of information as we move into artificial intelligence 2.0 is, what do the physician want out of from the result of a machine learning algorithm? How detailed the information do physicians want? For example, do physicians want only the person is going to have this outcome or it's not going to have? Or does the physician want a percentage, a probability? Or the physician wants something more complex, like an uncertainty graph, confidence intervals, and so on. So we're trying to first find out how much complexity of predictive results do physicians prefer. Okay, this is the first part of our study. In the second part, we're going to do randomized controlled trials for machine learning algorithms, where we're going to give some doctors, some physicians, the algorithms, the result of the algorithms, and then the others not, and see how those two groups of patients from these two groups of physicians evolve, right? Are the risk of developing this specific outcomes the same, or does having this information about the risk change the probability of the patients actually having the outcome? Okay, so as of right now, we are in the phase of testing the usability of the app, see if the physicians understand, if it makes sense, if it's easy to use, and what do they want out of the results of the predictive algorithms. How complex do they want these results to be? Okay. So this was the presentation that I want to give it to you, and now I'm just going to talk a little bit really fast about some of our new projects that are going on. So this one is on oral health with our colleague Hawazi and Eleni, where we published this article last year for predicting tooth loss, and we got some very interesting results, which made us interested in developing a bigger study, which we just got funding from the Harvard School of Dental Medicine, and we have some other grants that we applied to, where we're going to use multinational, diverse, longitudinal data from Brazil, Japan, New Zealand, and the US. Okay, this is a very interesting area that we have been working on our lab, is to see how generalizable are those algorithms. So if we develop an algorithm that makes smart decisions here in the US, intelligent decisions here in the US, does it work equally well in Brazil? Does it work equally well in Japan? Does it work equally well in New Zealand? We're still not sure. Okay, spoiler alert, we have been finding that even within Brazil, the quality really changes a lot from city to city. And so how do we identify this, and how do we correct these algorithms for working somewhere else where they were initially trained? Okay, what do we need to do to get this algorithm that was trained in one place to work pretty well in another place? How much new data do we need? Local new data do we need to make this algorithm work? So the longitudinal multicentric studies are very important for this. And we also have a new study now with Augusto here from UT Health in Austin and from the Dell Center, where we're trying to predict, to develop machine learning algorithms to predict the double burden of malnutrition using data from a multi-ethnic South American children and adolescent sample. So we're also very excited about working on this partnership here with UT Austin. So I want to finish by talking to you briefly about some new technical challenges that we're very excited in machine learning for healthcare, which is a very exciting field to work on, machine learning healthcare right now, because there's so many things to discover, so many things to work on. We usually do a study and then 10 other studies end up following from this first one, 5 new ideas, 5 new areas of research, because it's a very new field in the sense that, okay, prediction existed, but now it has opened up so many opportunities. So I would really encourage graduate students and even undergrads that are interested in science, because if you're curious, it's the best. It's one of the most fulfilling areas to work on, because there's so much going on, and it's going to completely change healthcare in the next few years, bringing better decisions, especially in disadvantaged areas. And there is so much scientific discoveries to be made here. So I'm going to briefly talk about some of the technical challenges that we're most excited in our lab. First of all, fairness, right? It's a big hot topic on Netflix and on media in general, right? We have a lot of documentaries and a bunch of books on this, and we're working on identifying the presence of prejudice in algorithms and how to fix this, how to automatically fix this. So it's an area of research that we have been diving on, and we're very excited to work on this. Another one is federated learning, which arose from the challenge of how do we keep patient privacy in the era of big data, right? And the idea behind federated learning is, instead of transferring patient data, we transfer the algorithm. Okay, so it's the algorithm that moves around and learns, and then it goes to data from a hospital, the data from the patients that remains in this hospital, it learns, and then moves to the other hospital, and then learns there, and then without ever the data from the patients ever leaving these hospitals. Okay, so this is called federated learning, which has a lot of technical challenges. For example, how do we make sure that the algorithm is not overfitting, right, on a specific hospital? How much do we let the algorithm change and learn from each new hospital? And then a third one that we're also very excited. So another technical challenge for machine learning healthcare, it's what we call online learning or continuous learning. It's the algorithms that as the data comes in and the algorithm makes prediction, it learns from this new data too. Okay, so instead of being a fixed algorithm, it's a continuous algorithm that keeps on learning as it makes new predictions. Okay, I used to say in my talk that things in healthcare never changed too much, and then came COVID, right? And everything changed from one year to the other in healthcare. So it's going to be important for us to develop this kind of algorithms that are able to adapt as things change, especially now with the rise of machine learning healthcare. As it changes clinical practice, the algorithms are able to learn from the new realities and the improvements in healthcare. So if you're interested in machine learning, there's a lot of really good sources to learn from online, on Coursera, on Udacity, and a bunch of talks, a bunch of lectures on machine learning for healthcare. I, of course, suggest mine. I teach the graduate level course, Machine Learning Healthcare at the University of São Paulo, and we have all our classes from late last year, so it's pretty new, it's pretty recent for machine learning healthcare. It is in Portuguese, but we have something, a very interesting technical innovation called machine learning that is able to translate in real time what I say in Portuguese to subtitles in English. So if you're interested, you can get the subtitles in English thanks to machine learning. Okay, so I want again to thank you all for having me. And it wouldn't, no, there's one more. No, you just clicked outside. So okay. Oh. Nothing of this would be able to be made without the amazing team that we have at LabDeps. We have over 20 researchers from undergraduate, masters, PhD, postdocs, professors on sabbaticals, and so on. So it's thanks to all of them that we're able to do this. And I want to welcome everyone to come visit beautiful São Paulo, Brazil. It's always with open arms there. And here is our website if you want to see some of our recent articles. Here's my Twitter. Again, it's in Portuguese, but through the magic of machine learning, you're able to translate the tweets. And here's the Instagram account for our lab. And here's my email, alexdiasporto@usp.br. If you want to send me an email. I'll be here in UT Austin up to Monday and available to talk with any of you that are interested in talking about machine learning for healthcare. Our lab only does this. We only work on machine learning for healthcare, so we're very up to date of the new strategies and the state of the art, and we're always very interested in collaborations. So if you have an interesting data set that you think would be interesting to do some machine learning, you can talk to us. We usually have some of our researchers very interested in this type of collaborations. So thank you very much.
Thank you, Alexandre. It's pretty good talk. So we go ahead for some questions. I have one, the first one. And make sure you type your questions in question box. Of course, I have a politician question. So first question, Alexandre, is the current Brazilian governments have been very dismissive for COVID. How this affected your job, your research job?
Yes. So yes, it's not only COVID, but overall science, right? We have I believe the only president that has not been vaccinated, according to himself, and he's very proud of it. But he does not represent our people. He won't. He's passing as president, and so it's very unfortunate that we have this situation. But the good news is that the outside world is still investing in science. So as of right now, we have, as I told you, funding from Microsoft here from the US, and funding from Harvard here in the US. So we're able to do really well in our lab. And yeah, it's a very important thing that we do not see leaders as representative of their people, especially now what we have seen in the war, right? We have to be able to separate the people from the leaders. And then, yeah, in Brazil, it hasn't been hard. We just try to ignore the press as much as we can. We have been really successful in that. So yeah, and always remembering that it's just passing. It's just a phase, and you know, other countries have gone through really bad stuff, I won't say which country, but you can imagine, and we will survive too.
Second question is, what are some surprising challenges you faced during this research?
Oh, we find it all the time. Very surprising. As I told you, the thing about not needing many patients to have good prediction in some studies. So we have the wrong view still that okay, machine learning is only for big data and so on. No, it's not. I would rather have much less patients, much less sample, really small sample, but with good predictors for predictive variables, then have millions of patients only with irrelevant factors, right? Irrelevant predictors. So this is a very important one. Another very important one, which we have a result that we're sending for publication in the next few weeks, is that it's better to have less patients if you have local patients from where you're trying to use this algorithm. Okay? We run a bunch of experiments in Brazil, all throughout the 5 regions of Brazil, to see, okay, is it better to have more patients or locally collected data from the local patients that we're trying to predict? And it's better to have less but local patients. So it's going to be a very interesting result for machine learning healthcare, especially as it was done in Brazil, which is a country with huge inequalities, right? But even in huge inequalities, even if we get closer, the hospital close to each other, it's better to only have your own the data from your own hospital. So it's going to be a huge area of research in the future as the startups start to sell the algorithms, and it's going to be an algorithm trained in the US and then sold to Brazil. And what we have been seeing is that it doesn't work so well. It doesn't work well at all. Even within Brazil, it doesn't work well if you move the algorithm from one place to the other. The predictive performance really decreases, and you need to train with locally specific data. Of course, there are a lot of nuances in this, and there's a lot still that we need to learn on this, but it seems to be the case. So both of these results are interesting and surprising to us.
Do you incorporate biomarkers into machine learning? If yes, how would you go about collection of biomarkers so that it's sustainable for machine learning?
Well, exactly. So it's always a trade-off, right? We want the best data, the most detailed data, but as we want to put this algorithm in disadvantaged areas, we're not going to have the very high quality clinical biomarkers or exam data, right? So what we usually do is that we start with every single data that we have, and then we move down. For example, now we try to take out the most expensive variables, right, and see if the performance remains the same. What is very interesting is that the algorithms really like clinical exams, as opposed to survey questions, right? Usually, if we have both of them, if we even have a blood count, and we have hundreds of survey data, the algorithm really likes a blood count for plenty of severe outcomes. And then something that I always tell my students is that we know we have strong variables when the algorithm just ignores age, right? We think that age is a very important predictor factor, but if we have the actual situation of the patient, because age is just a proxy, right, of the health condition. If we have an actual exam of the patient, if we have good predictors, the algorithm just excludes age as an important variable. So this is a very small but interesting trick, is that if the algorithm is just ignoring the age of the patient, usually means that you have very good predictors, very strong predictors, because you're actually measuring the health of the patients and not a proxy of the health, which is a number, right, which is just age.
Could you please elaborate on the appropriate sample size for machine learning analysis?
Yes, exactly. So we do not have a sample size that is acceptable or anything. We usually work with every single data that we have. So if you're a hospital and you're trying to predict something that is very important for your hospital, what is the amount of data that you need to use? You need to use everyone. You need to use every single data that you have in this hospital. The more the better. If it's quality data, right? The more the better. And you'll see if with this data you're able to predict this outcome that you want to predict or not. Okay, so if you're able to predict really well, you can use less data if you want to, but usually use all the available data that we have. And how much do we need? We need strong predictors, much more than a large sample, much more important than a large sample. We need strong predictors. If you have millions and millions of patients only with survey data, for example, what is your favorite color, or what is your mother's name, or something like that, that do not have a very strong predictor ability, you can have millions, you can have billions of patients, and you're not going to have a good prediction. But if you have a small sample, and we have cases of using only 100 patients, and we still get pretty robust, strong predictive performances. So I would trade any day of the week a lot of patients for good predictors, and even good predictors much better than a lot of predictors.
Someone have one more question or two?
And as you write down new questions, I want to talk about something else that I said about variable importance, right? Some people still have an idea that machine learning is a black box, or machine learning, you have no idea what is going on within the algorithm. It's not like that at all. So machine learning is a bunch of mathematical functions. So if you want to take a look at it, you can look at it. It's not magic, it's not a miracle. And then even if it's just a bunch of functions and you want to understand what is going on, you have what we call explainability methods, where you're able to, after you do the prediction, so the goal of a prediction is to make predictions, right? It's not to find associations between factors, is to make a prediction. So after you make a prediction, after you do everything that you need to do to have a robust prediction, you're able to, yes, find out what the algorithm is looking at. Okay, we have a bunch of methods right now. We have hundreds and hundreds of methods that are able to take this information out of the algorithm. So we're able to tell you at the end, and we always do that in every single study that we do. In the end of the study, we're able to look into the algorithm and say, okay, the algorithm looked at this variable, at this variable, at this variable, and at this variable. So we do have explainability in machine learning, especially in machine learning for structured data. We have a bunch of techniques. We're able to, yes, explain how the algorithm made the decision, and to yes, explain what it's looking at and how it's making its decisions.
The last question: did you cover the difference between machine learning and regression?
Okay, so you can use logistic regression, and we do use logistic regression or linear regression as one of our algorithms. What we usually do, we test like 5 to 7 different machine learning algorithms, and we consider a logistic regression and linear regression an algorithm, a machine learning algorithm. And then we have a ranking at the end of which algorithm was the best. Usually logistic regression and linear regression are not within the best, right? The state of the art right now is, as I said in the beginning, gradient boosting trees. So we usually have in the first place XGBoost or LightGBM or CatBoost, and then maybe we have some random forest, and then close to the bottom we have the logistic regression or the linear regression. You can indeed use them for make prediction, of course, right? You do an association study, and if you fill all the betas, all the values of your regression, you get a Y, right? You get a prediction. You can use it. But the thing is that logistic regression and linear regression are very simple. So in most cases, it can happen that in some cases it can be the best algorithm. It has never happened on our lab, but it can happen in theory, right? But the fact is that logistic regression and linear regression are very simple, and for more complex data, they're not able to understand the nuances within the data. So you can use them to make predictions, of course, but it's not within the best algorithms. If your goal is prediction, right? If your goal is inference, they're perfect. Okay, to find association between factors, they're perfect. But for prediction, especially for more complex data, you usually want algorithms that are able to capture the finer details on the data.
To complete this question, Alexandre, did you face a challenge in communication your methods or findings to know ML folks when you began your ML journey? If yes, how do you overcome this?
We still do. We still do a lot. We still have the reviewers too, right? That usually think that they usually know about machine learning, but have a very superficial knowledge. We try to take this lightly. We try to understand this, that a lot of people are still learning about it. A lot of people have a lot of prejudice. A lot of people think that we're trying to say that, oh, everything that has been done in science is rubbish up to now, which is not at all the case. As I told you, it's a different area, right? Inference, you have inference, which is to find association between factors. And then you have prediction. You can do prediction with logistic regression, it's fine. With linear regression, it's fine. It's not going to be the best prediction. You usually want the best prediction when you're doing prediction, right? The goal of prediction is to predict. So usually you want to get the best one, but still some people feel attacked that we're using more complex data, unfortunately. But we try to explain to them that we're not trying to overrule anything. We're just trying to make help with hard decisions in healthcare by processing the data the best way we can, the best way that we have right now, with the best methods that we have right now. So we try to take it lightly. We understand that some people may feel like we're trying to say that the inference is wrong or something like that, which completely different field. But yeah, we try to always educate. Now, it's a very important thing in machine learning is that we're very open. We're a very open community. We like to give our codes for free. We like to give our lectures for free. We like to the education part is very important to us. So we're always happy to help and to help with some doubts and with some questions. And yeah, so we usually take these moments to explain and try to get more people on, because we really need more people. So if you're a graduate student, you know that the machine learning jobs are really the thing right now, and you have a lot of options. And because a lot of companies are seeing that getting good information out of data is really important, and they're trying to hire, but we still don't have the many professionals as we would like. And as I told you, if you want a scientific career, there's so much to learn in machine learning. There's so much to discover in machine learning. So many very exciting scientific challenges to discover in machine learning, and also practical and important and life-changing challenges in machine learning. So I would like to end this by inviting everyone. If you have any itch on you to go into machine learning, do go into machine learning. You can work in the academic area, you can work on industry, you can work whatever you want, and it's very exciting, and you can really make an impact in the world. So yeah, I would welcome everyone to come to our.
And it looks like we covered for our questions, and thank for everyone to attend the webinar this morning, this beginning afternoon. We really appreciate everyone be here. And remember, this webinar will be archived in our website, again, mesdcenter.org. And I want to say thank you again for Alexandre to be here, and say thank you for our center director, Professor Diana Rocher, and of course our research assistant, Amelia. And without her, it's not possible this. Thank you, everyone, and have good lunchtime, and see you the next time.
Bye, guys.